Anyone from the hospital online?
Hi.
Good morning.
Oh, good morning, everyone. I'm Shade, is our cardiac surgeons. Dr. Kim Hojin is, you know, that Alan Yeung from, Stanford. Dr. Gang is our staff, junior, and our family here. And Dae-Hee Kim is from the echocardiograph lab for the support our imaging. First of all, I'd like to thank for you all for joining us. And so this year's one, AP VALVES 7th, 2018. Everybody know that the type of procedure is, established a standard therapy for a selected patient of a symptomatic aortic stenosis. We've discussed a lot, and so we have very lots of interesting cases for a little bit extreme, so for the live cases from the Asan Medical Center. So this is a live cases including the bicuspid and valving valve for prosthetic valve failures, and also we're gonna try to have a procedure for aortic regurgitation, right? It's not standard operable procedures. However, we're going to show, how work type of procedure is. And today we prepared, especially I'm very happy to have Alan here. Actually, he, you know that he has been, I would like to talk some things. He has been last almost 10 years. He used to be my mentors, my old friend, and still, we are working together. And today, as we have strong cardiac surgeons, he can do some procedures for like this, and I'm very happy to support him too, right? So, Dr. Gang, would you introduce the case for us?
Yes, this patient is a 76-year-old gentleman admitted for dyspnea on insertion. He had a history of PCI at LAD and RCA 7 years ago, and the echocardiography showed severe degenerative aortic stenosis with bicuspid aortic valve. And he also has a history of esophageal cancer 10 years ago and received concurrent chemoradiotherapy, and there is no evidence of disease. And STS score is 1.7%, relatively low risk, but the patient is very frail and history of cancer, so we decided to perform the TAVR for this patient. And the echocardiography showed that normal LV ejection fraction and aortic valve area 0.77 square centimeter, and the mean pressure gradient was 442 millimeter mercury, and transaortic Vmax was 4.1. And coronary angiogram showed patent stent with mild disease.
Yeah, I presented echo image right now.
Okay, right now.
So live.
Yeah,
Unfortunately, can you hear me?
Yeah. All right.
Yeah. Unfortunately, this patient has a poor echo in the spine position. Please don't expect too much for the echo. But in this parasternal long axis view, you can see severe
some echo image.
Yeah, severe opening limitation right here.
On the screening.
Yeah, now we have it here. On color flow image, you can see a flow acceleration indicating aortic stenosis. In apical view, every function looks good. Interesting, the significant functional MR was noted.
All right. Right, pre-evaluation echo, and actually we have our own, CT algorithm. So we want to explain, the parameters of CT.
Let's change back to
findings,
presentation.
Right? Dr. Gang, would
Yes.
you show that?
Yes, we comprehensively analyzed the CT image, and the CT showed that the valve was bicuspid, and the annulus short diameter was 23 and long diameter 31.4, and annulus area was 608 square millimeter. Next. And the interesting is the sinus valsalva is not so large, despite of bicuspid valve. The sinus annulus area to sinus to annulus area ratio was just 1.2, and ST junction
In
was not
average,
so big.
bicuspid, the patient had a large sinus,
Very
large
large,
aorta. However, particular for this case, the sinus annulus ratio is 1.2, compared with the mean sinus annulus ratio is quite a small, kind of a straight,
Yes.
aorta. ST junction is also very narrow. Okay.
And every outflow tract size was sufficient. And next, and the calcium amount is not so large, just total 112 cubic millimeter, and there was some calcium in the right and left fusion cusp. And coronary height was sufficiently high. The left coronary artery height is 15 millimeter, and RCA height is 11. Next, so this is the sizing chart for this patient. Because the patient has a bicuspid valve, so we decide to start from the 0-point oversizing. So we decided to select the 29 millimeter Sapiens 3 valve with 2 cc underfield. Then we'll make just 0 to 1.1% oversizing. Then we will check again and we'll decide to treat or not to treat with a post dilation.
All right, so we actually selected Sapiens 3 for this bicuspid, aortic stenosis. Alan,
Yeah.
would you have any, size selection or, device selection? Would you
Yeah.
comment on that? Bicuspid?
So this is a little bit of an unusual bicuspid in the sense that, from your CT morphology, looks like there's 2 leaflets, but I haven't seen it in motion. But you can see from the aortic root shot that looks like there's at least sort of 3 sinuses, maybe they may be different sizes. So sort of a, type 0, but, with 3 sinuses type of morphology. The concern usually is to make sure that the calcium is obviously enough to hold the valve, which seems like to be. And also if there is any calcified raphe or anything like that, to make sure it's not too heavily calcified, so when you expand the valve, it doesn't puncture the sinus, for example. So that's important to look at. So I think so far looks favorable, and that, for him to have stents already, so who knows, he might have to be re-instrumented at some point with other coronary disease, then a sapien would be probably easier to re-access the coronary, likely, hopefully clear. So I would probably say sapien 3 here is a good choice.
Any other?
Yeah.
There is a preference for the device selection, the Sapiens 3
And
Eberhard?
Evolute. So in bicuspid, traditionally in the past, we've used a lot of times is the Evolute because you can reposition. But as we get more experience with using the Sapien 3 for bicuspid, it works pretty well too. So I think the choice are not so clear, and your other reasons that you could use the balloon expandable here, the coronary access, the ease of use. I think that could be a good choice here as well.
Area oversizing concern.
Yeah.
What was your selection? Is actually we want to start. This is not too much calcium,
Yeah.
so we want to start with a 0% oversizing.
Yeah.
A little bit smaller.
Yeah.
Actually, we have our cutoff value 15% of area oversizing.
Yeah.
However, in case of bicuspid,
Yeah.
just we reduced, ratio of sizing. What do you think?
I think that's a good conservative way of doing it because on 29 it's about 600, and so as you said, it's about 6% oversized, which is probably okay. But because of the bicuspid nature, going down a cc or 2 to get started and wait and see how it looks like to further touch up, I think will be quite reasonable as well.
Right.
So one question is whether, I'd like to hear the panel, do you routinely pre-dilate in this situation before putting a sapien? Or do you like to kind of release some of that tension before going in with the sapien 3 valve?
Any comments from the panel? Yeah,
I
John?
would not do the balloon dilatation. This bicuspid not really calcified. If I do, I agree. I will probably in this case I will reduce the volume a little bit because there's a smaller ST junction and also low. Otherwise, if ST junctions pretty big, sinus big, I will not reduce any volume. It's not very calcified bicuspid.
Yeah, I think we would do the same. We almost never predilate for any valve, but certainly not for the Sapien 3
So-
these days. And this doesn't look particularly bad, so I think going directly ahead would be reasonable.
They don't.
Yeah. Sorry, go ahead.
They don't want a predilation. How would you do that? To be honest, it's our routine practice. Actually, in almost all cases, we did predilation. Dr. Seung-Jung can do that. There's our many junior colleagues can do have a procedure. And so we, to be honest, made some routine for that. So, however, what would you do there, Dr. Kim? Direct stent or predilation? So?
It is our routine procedure to predilate, but it's suggested by Dr. Yeung and other panels. We just proceed with it.
Direct?
Direct
Okay.
implantation.
Okay, would
Show
you
that,
show
maybe show
that?
the picture, yeah.
So we have already passed the wires, and in order to save the time, would you make it, all right.
발 놓고.
Would you show us some
The
air
shot,
totem
right?
for
Yeah.
that? Air
Which
totem?
wire is that a Safari or
It's
Confida?
a Safari,
Safari.
small.
May I ask one question? Who is the first operator in this case?
우리 cardiac surgeon is here.
Cardiac surgeon.
I am the
It's
Right.
quite the shocking appearance in the Korea.
Is
They
it?
really appreciate that the other surgeon should be respect this kind of
Dr. Hong?
the live case
That
demonstration.
wire, yep.
All right.
So 29 always has a bit
Okay,
of
I'll
resistance,
help
so
you.
you need to push pretty hard, especially if the
Alright.
vessel is a little small. So I always kind of in the cath lab jokes that we are like for guys to have a baby, so you have to kind of push, type of thing.
Wow.
So you say they are grunting now. This is
Sometimes so very small, difficult to push.
29 is always a bit
Alright.
of experience.
29.
We have to keep working out so we can
Yeah,
make sure we get
exactly.
deliveries.
That deep breath, bear down,
Alright.
push.
Whoa.
it's very
What's the low?
Slowly.
Sure.
Okay.
It's
It
moving.
walk. Yeah.
It's moving.
Yeah, there it goes.
We cannot do. He can.
yeah.
Okay.
Yeah.
We have no powers, right?
Yep.
You.
Who wants to do that?
Okay.
Yep.
All right. So. We
So
have
we're pretty coaxial here in the AP,
Alright.
so we're good.
Is your
put the
microphone? We don't hear you so well.
system out,
It's on
Okay.
right. Talk right into it, I think.
and then so we're gonna
Roll it in.
okay. Pull the system out to
The dot lines up,
all right.
and then go to LAO in a minute.
Almost there.
Will be nice when we have the Ultra and we don't have to do this anymore.
Yep.
Great. And
Then I'm going to go to LAO
just
so
minute.
that you can see.
just a minute.
You
Hold
press
on.
something?
So
Okay.
I want to
If
pull
it
the
is available,
lock.
could you show us the ECG and the
You want
hemodynamics
to
on
ease
the
up
screen?
the tension.
All right.
Okay.
Release tension and a little bit further. 0.5 millimeters.
Okay.
Okay, good. Okay. All right.
Let me go to LAO.
Push in.
And
Slowly.
you have this prepped with 2
Okay.
cc's below
On the
nominal?
fill.
2 cc's under?
Yeah, on the fill. Oh, great. It's quite easy, right? It's,
Now you can need to pull back.
okay.
Can we see the hemodynamics in the
No
EKG,
problem.
please?
Looks so far okay.
Okay, no
Blood pressure
problem.
is 96 to 43, and EK shows the
I want to just
sensor
push
rhythm
back.
with some
Push it
British
back.
very stable.
Okay.
Lock. Pull back the pusher.
Push back. Okay.
Pull back. Yeah.
Don't forget to do this. I've seen it. It's
Allow-
not pretty.
allow.
Yeah.
Okay, system in, so it'll be good.
Yeah,
Perfect.
Yeah, we can see that.
Okay,
Maybe
lock.
now we can see
Lock
the
down.
hemodynamics.
Okay,
Can we see the hemodynamic screen instead of the hands now?
right.
Can you
No
show
problem.
the
problem. You don't like our hands?
We like your hands.
이거 누가요? 이거 누가요?
That's fine.
Good.
도훈
Okay.
잡아.
You want it? Okay. So you want it?
Okay, would you
Do the
show us
testing?
fluoro? Okay, test please. 어땠어요? 이제 little bit?
A little deep.
Okay,
Below 2 LB.
I'll be.
Always sometimes want to
Wine.
call out the right, especially if you're not doing it, to tell people deep or not deep is all
Okay.
relative. So you make sure that people understand it's LB or aorta.
Test
Picture
again?
again? Still a little deep.
Okay.
Come
You
back a bit.
push the wine in? Okay, good.
balloon isn't quite centered. Your balloon is a little ventricular
Yeah.
compared to this valve, so
Test.
you want to go a little.
Test again. What do you think?
Yeah, so the
This
dot
is
is a
the
little bit.
Okay,
bypass
I
valve.
think it's okay.
Maybe the valve should be a little bit higher than the other.
Yeah.
Test.
usual.
Because
I
it's
think it's perfect.
Oh, that's good.
All right. So.
Okay.
We'll check that one.
Pigtail.
Ready?
Pigtail.
Looks pretty good.
All right. Okay.
Oh,
Okay.
so,
It's good. No problem.
okay.
All right.
Okay.
Good.
Yep.
Okay. So ready? Okay. Pacing on.
Facing on.
Contrast.
Okay.
Inflation.
Inflation.
1,
Two,
Michael.
three,
3, 4, 5.
Deflate.
Deflate.
And pacing on.
Oh.
Facing on.
Okay. Device on. Okay. Fine. Great.
Good.
Wire
We'll
in,
wait a bit. Oh,
please.
you'll wait there.
All
Yeah,
right.
wait, right? Yeah.
Go further. I don't like the image too much. Too
Okay.
complex image, right?
So you do several things different than we do.
Yeah.
We leave the pigtail down in the root and trap it there, and then take it out after. In all cases,
a big
or
hole.
valve or
Interesting.
outwards. And we deploy much. We
That's
deflate
so
much slower. I don't, Alan, is
slower.
your practice that quick or slower?
Much slower. We basically go up, you know, with the waist, and then because you can do some fine adjustment at that time if something happened, and therefore you can still have the operator coordinate with you. And you know, I see Dr. Park always the team pretty much do it quickly. So
튜브 좀 제자리.
you know, I think you know this, we don't want to change their practice because you know, they'll be used to
Do what you're good.
what they're doing
Yeah.
as
Alright.
well. So, but I would say that generally we do it much
Slowly.
slower. But it's okay. But
It's
I mean,
okay.
I think it's not one way or the other. You can see the valve jumped up a little bit when we quickly do it because it will find some natural position. But that's why sometimes going slow
Alright.
may help a bit. Let's see what it looks like.
Do you still believe in the device would be a little bit higher and compared with
In
the
the
other?
bicuspid, you mean?
Yeah.
Yeah, I think it's a little higher is better, but I think it's so minor that probably cannot adjust it.
All right. So would you show us echo evaluations
look
of
great.
people?
Hemodynamics looks very good. We're going to do some thoracic echocardiography to see how it looks like and whether we need to go and touch up a bit more for paravalvular. It's interesting, if you look at fluoroscopy, you don't see it anymore, but there's a little indentation of the valve because probably that's where the calcium little
Yes.
chunk is. Then when it got pushed up, it's kind of sit there.
And there was a pretty good sized piece of calcium up by the left corner there.
Yeah.
What about the severity of the functional mitral regurgitation?
Yeah, that would be
at the
very
beginning,
interesting. I forget to talk about it. We can check the mitral
Yes.
regurgitation after as well to see whether that actually get better after the aortic valve.
I think the trivial paravalvular leakage here. Yeah,
Trivial?
Yeah,
Still
twice.
looks
Twice. Yeah, very pretty.
Many related wire related central.
So it looks like it is trivial or, you know, and MR, at least in my quick eye, or
Yeah,
looks
MR
better.
was much reduced.
Moderate.
Yeah, it looks
Yeah.
better. It was quite a big jet before. So that's why we never make judgment of what to do with the mitral valve until we are done with the aortic.
Decrease mitral regurgitation.
Yes.
Yeah.
Right.
Yeah, I think we say
Excellent.
it fell at least a
Alright,
grade or
great.
two
Great.
of this one.
I mean, the echo windows aren't great, so I'm not.
Yeah, we
It's
wait
hard,
and wait.
hard to
get
be
better.
sure about. I mean, the mitral, I think you can see, but the aortic,
Yeah.
I think you're going to need an aortogram.
Yeah.
I think, too.
Yeah, we do an aortogram once we.
The functional MR just mild.
Professor Kim is the expert for the
So they do it all. You know, I think he's actually in a position that can do it regular transthoracic. His picture's always been a little snowy, but
It
actually,
just doesn't have great windows.
yeah, a little snowy from that. So, but that's a pretty.
And I don't see anything obvious there.
Yeah, once
Okay.
he's settled, we can take this out
Yes.
and we can
Yes.
All
put a
right.
pigtail in
And,
or something. Oh, sorry, you had it.
okay, fluoro, please.
Yeah, you had
And
four.
And then we don't. Okay, why not take her aortogram first?
The wire's kind of stiff. You don't want to.
All right.
We'll just change it up
All right.
to be
Right now.
proper.
Good. Perfect.
You have a pigtail.
Mhm.
I need to pull a little bit.
You don't. We don't need any more post dilation, right?
I don't think so.
All
I
right.
don't think we post dilate. I think it looks pretty
True.
good. And I'd rather not push that calcium further.
True.
Just need to pull a little bit.
Okay.
And that 29 is very stiff there.
All right. Okay. Wire in. Ooh.
It's just a very
Would
Would you
Okay.
complex.
routinely measure the LV
Yes.
pressure?
I do. And if
It is.
normally would do a pigtail in the LV now.
Right.
And also the pigtail is much softer, so you can evaluate the AI with the root shot better.
to
So sometimes with this guy, it's too stiff.
To be honest, I would like to finish the procedure. Right? However, my colleagues, Dr. Wang and Jung-Min Ahn, they want to do the pigtail.
They are right, SJ. You give them a little, because the wire sometimes push against the leaflet, and you have more AI.
I don't like that.
You just put everything. Relief.
All right. Okay. Picture here.
So let's give a chance to measure the gradient. So 29 should be no mean gradient more than 4, for example, in most of the data. The big valve, the gradient should be pretty small.
4.
I see the hemodynamics.
Okay, good.
Diastolic pressure looks very good.
Yeah.
I see a good dicrotic notch. And I don't think there's much AI.
Yeah.
if
So
any.
so I think we just kind of for documentation purposes.
Although there's no obvious AI through echocardiography, but it is bicuspid valve.
Yeah.
So I think we still need to know whether
Pigtail is not
have
equal, but something.
after the valve implantation.
I think 2 cc on the field is quite good.
Yeah.
Nice choice. Hold on, what do you
Yeah,
think?
I think it's good.
29, 2 cc on the field.
And with that funky calcium, it's always good to be a little conservative.
Sure.
Because that calcium, you don't know what it would do.
Oh, right.
Whether make it really
Exactly.
big and then push against the sinus and
Sure.
something happen.
Right.
So,
So did you see the pressure wire? Pressure
can you see here?
Pressure monitoring?
Yeah, you do.
on the screen?
Back.
Okay, great.
So we'll just do a little flushing and make sure
all
everything
right.
is zeroed.
Zero with you.
Yeah.
All right.
The proper hemodynamics, you have to
You
zero.
can expect that
Looks
one.
good.
All right.
Very good.
Looks very good.
Pull the pigtail.
Pigtails out.
Okay.
Pigtail out. and,
Diastolic pressure is 25
all right.
LV.
Good.
Yeah.
Perfect. So why don't you take a
So we can do a little aortogram.
EKG is still
Normal.
narrow.
Yeah, still narrow.
Sinus.
hypertension?
We always don't want to make sure blood pressure come down a little bit before you pull, right? Because otherwise it'll be bleeding all
I
over the place.
really bad experience with the bicuspid area, right? A little bit small oversizing
yeah,
can make
yeah.
it a lot
Big trouble.
something.
Yeah. So I think it's good
Calcium.
too.
Okay, right now.
Ready?
Ready? Aortogram? Push in.
Very nice.
It really traced a little bit on the top
Trace.
there, near that calcium flex thing.
Oh, really?
Yes.
I cannot see that. Oh,
Get the
really?
glasses.
Oh, I cannot see that. And the other view was
Tiny bit right at the.
out of view.
Yeah, tiny bit
Just a
on near
whiff.
the calcium thing.
We'll check on
And
that.
Hold on.
also for the where's the coronary takeoff is
Okay, I
near
got
the big
op-
cell
okay.
of the sapien, so you can get access. Should be no problem if you need to down the
Oh,
road.
I want to show there's absolutely no trace.
Okay.
Okay, a little bit more cranial. I can make it. All right.
If you
Start
get
it.
uncrossed, it'll be very
Start
difficult
it.
to
All
tell.
right. And so, okay, take a picture here. Really, I want to show what's happened. Is magic. Okay. Injection. Ooh, nothing.
Very good. That's good.
Very magic.
You cannot believe this one?
Yeah, if you
Alright,
hide
so-
the jet behind the valve, it's, you
Oh,
can see it.
absolutely. I cannot say anything, right?
I learned a trick, go back, I'll change the angle and get rid of the AI.
That's the
I think it's a
important.
very good.
All right.
Excellent job,
good.
excellent job. Sorry that we're not pre-dilated, but I think it'll work. It'll work.
That's,
All right.
that's a great case. I think really illustrates
you.
that undersizing with the bicuspid valve is a reasonable approach
Right.
to go. I think your algorithms seem very, very nice, and it's good to have someone taking as much care to define that. Are there any other comments from the panelists? Otherwise, should we go to the next room?
Okay.
Is they
All
ready
right.
for us?
All right.
Thank you.
Thank you for
Yes,
the,
thank you. Beautiful job.
One question, sorry. One question, sorry. The coplanar view in a bicuspid, here. A coplanar
yes,
view in the, sorry.
Yeah, okay. Question from the audience?
Coplanar view in a bicuspid aortic valve for SAPIEN 3. How would you
Yeah,
go
that's.
about it?
I mean, I think in this case, it was sort of tried. There were 3 cusps, even if it was a bicuspid valve, which made it possible to determine that. But obviously, if you only have 2 cusps, it's very hard, and that's one of the real challenges with doing bicuspid valves. sometimes is one of the advantages, I think, of using a core valve is because it's a little less sensitive to getting the coplanar view exactly right for that. So I think it's, it's one thing we struggle a lot with. I don't know, John, do you have any tips, tricks, anybody?
Bicuspid a little difficult to do the coplanar. Even CT sometimes may not so accurate.
But that's very good. That's a very good view.
But overall, I think the bicuspid a little different tricuspid valve. It's even a little bit tilted. I think it still will be okay. I don't think it will be a major issue because your usual code is a two. You can see is one small, one large. So even like before we started bicuspid way early, like even at the beginning, we never recruited the bicuspid valve since started. So we only use the fluoroscopy to determine the angle. So it seems like not a major issue with bicuspid valve. I don't know what
I think it's just, it's hard to know for sure. I mean, I think because you like to see those nice three cusps, all lined up, and you only have two. And when you only have 2 points, you can't really define a plane very well. So it is a real challenge. I think it's something that we all struggle with. Does anybody have figured out a trick? If you have, please tell us, because I don't think there's anything other than to try to really just make sure you have something that seems sort of flat that you're working on.
I think that's right. Yeah, it's a little bit of eye of faith. And
yeah, but it's and again, I think the core valve, we are much less sensitive to coplanar views when we're deploying a core valve. So perhaps that is one of the nice things about using a core valve in that case is we just kind of deploy in the LAO view and off we go, and you can reposition if it's horrible. So that's a nice aspect of it. Okay, well, thank you very much. So we're back to the other lab. So Eberhard, and do you want to introduce your whole team?
No, that's Dr. Ahn. I'm just...
Okay, Dr. Ahn, you introduce the team, please.
Yes.
Good morning, chairman, Cohen, Dr. Hong, and Dr. Jiang Lee. So this is my life mentor and master, Dr. Grube, and another my colleagues, Dr. Go and Dr. Lee. So good morning, and then.
Can I just say one word before you get the case? Because obviously SJ did it in 20 minutes, putting us under pressure, but so we have a little bit more time now.
You have as much time as you like.
I'm glad, yes, and I learned a lot, David, from your core valve sapien comparison. SJ, no sweaty shirt, is walking around, and so he's very relaxed. That's what he usually does. I'm glad that you noticed it was not a bicuspid, a tricuspid. No, I'm just kidding. But thank you very much for having me again. It's really great to be back. Many years ago, I started here with both SJ and Dr. Ahn when we did the first core valve cases. And I'm very happy, very proud actually, that we can do a nice case, hopefully. It is probably taking a little bit longer than the 20 minutes that SJ has shown to you and his team. Many good things are happening here, surgeon deploying it, and then Dr. Hong has noticed the TE, TTE issue. So it's very good. I'm listening, and when you said that you do deploy a core valve with the pigtail in place, or with the sapien pigtail in place, I'd like to hear that because I'd like to keep the reference. So many good things. Thank you for having us here again, and maybe now we can present the case to you.
Okay,
thank you.
This is another bicuspid valve.
Yes,
Dr. Go.
Yeah.
Oh, good.
The case is 18 years old female admitted to a hospital with DOE, and she has a history of hypertension. The echocardiography showed a bicuspid severe degenerative AS with normal systolic function. Past medical history contains she underwent the left subclavian artery stenting and the coil embolization for intracranial aneurysm in 2018. Next. So the cardiovascular risk factor contains a hypertension, and the SDS score is 3.12, so low risk profile. So next. Echocardiography shows the bicuspid valve with ejection fraction 66. Area is 0.35. Mean pressure gradient 104, and the peak velocity is 6.4. Wow. And next. So this is the annulus plane measurement. The annulus area is 413, and the short and the long diameter is 20 and 26. Perimeter is 73. And next. So the ratio between the sinus and the annulus area is 1.45, so it's relatively smaller valgus valve. And the ST junction, the ST junction to the annulus area is 1.16. Next, LVOT has a little bit smaller LVOT, so this patient anatomy is a little bit tubular. And next, so this is intercommissional distance, 4 mm above the annulus plane. The ICD is 24, so ICD by the annulus diameter ratio is 1.03. So landing zone configuration is flare. And next, the classification is 336. And next, the distribution of calcium is not extended to the LVOT. And next, the coronary height is more than 10. And next, so today, actually, we have chosen the Volta R for this patient with 29 millimeter. And next, and the peripheral is very suitable for the transfemoral approach. Next. Next. So, Professor Ahn, please.
So before selection of, before discussion the size or something like that, could you show us that echo imaging, the
Yes.
Dr. Kim, not TE, but
Can you
TE?
see the echo imaging? This is a routine parasternal long axis view. LV63 function looks good. In zoom mode, you can see a very limited, opening limited valve consistent with aortic stenosis. On color flow image, you can see a flow acceleration indicating aortic stenosis. In short X view, the cosm morphology was bicuspid. In apical view, every function looks good. Substitute tracing of aortic valve peak velocity was 5.1 meter per second.
Okay, David, I hope you've all seen this case. I think there are a few interesting things to consider, and I would like, since you're allowing us a little bit more time, to discuss a little bit here the sizing issue. There are certain things. It is a little bit atypical bicuspid, at least for me. It is not so much calcium. The distribution is not large. There's a big chunk, as you could see, with 390 in their measurements. So then what you could see on the intercommissural view, the distance is 24. And when you look back at that view, could you go back? Yeah, the next. That one. You see, if you look at this is, when you look at sizing, and I usually tend to undersize the valve, probably talking about core valve now, undersized, the fact is that the annulus is not the anchoring part in bicuspid valves for the prosthesis, so it's more the leaflets. And here you can see the leaflets really open a little bit atypically, almost round to the annulus. So the sizing issue here, when we were both discussing the case, as you could see, the perimeter is 73. It is borderline between the 26 millimeter valve and the 29 millimeter valve.
Yeah.
And so I couldn't make a decision, and since it's a live case, and we want to obviously have a good result, particularly after this excellent SAPIEN case, we were thinking of approaching it a little bit differently. To be honest, if this was not the live case, I would probably use a 29 millimeter valve here, given the fact that we don't have much calcium, that the leaflets open almost in a zero fashion. The raphe is very small, as you can see, and therefore probably the 29, I would take a 29, but I don't know whether I'm right or wrong. The other atypical, or if you take a typical bicuspid valve with more calcifications, a calcified or fused raphe, and all of that, I would probably go for a 26. So this is one thing. The other thing I would like to point out too, even though it's not really an issue, but there's a really hypertrophied interventricular septum, the bulge that you could see in the subannular space. Some people are irritated with that. Personally, I'm not. I don't think it matters, but it is just something to point out. And I think when we look at the pre-dilatation issue, here, when we both discussed it, and I totally agree with Dr. Ahn, here I would like to actually test with a 20 millimeter balloon, and he suggested it actually, to see whether we have a lot of leakage or whether we have maybe no leakage or a little bit. So that would help us in the decision-making process. Now you can argue between the 26 and the 29 there's not much difference. Actually there is, particularly in the bicuspid situation, 29 millimeter, if it's oversized, and I think it's by 11% oversized, correct? It tends to go a little bit deeper, the pacemaker issues, and since they have this excellent pacemaker rate of 4%, unheard of, for me anyway, I'm happy to follow their path. And he suggested to do the 20 milliliter balloon sizing to see what valve type we should be using, right?
Okay, good.
Any discussion points or any comments from your side?
Well, I think there's a lot of interesting points here. So are you still debating between the 26 and the 29
Yes,
valve?
yes.
So the balloon is going to be partly to help make that choice?
Right.
Okay.
And we'll do it together.
Yeah, good. And how big are the sinuses? Are the I mean, this is
Small.
a fairly small.
Small.
balloon. I'm
Small.
Yeah,
surprised.
small.
Yeah.
Yeah.
I guess that worries me a little bit about the
Yes.
29.
Yeah.
Yes. Agreed.
In that case, is there anyone who has a strong opinion as to which valve we should use?
James always has a strong opinion. So
James is right here. He's grinning at me.
I know.
I totally agree with your comments. The supply this valve is the mean gradient so high, and if you look at the CT and look at the aortogram, doesn't look like it's so tight, and particularly on the aortogram, it looks like. I agree, it's a typical bicuspid or not, because you can see the three cusp, and there's only I would say this is a non-symmetric, it's a sort of a tricuspid aortic valve, but it's maybe a more like functional rather than it's really bicuspid valve. And the calcification is really only located on one cusp. It's really global calcification. So that's, I just sort of whether there will be possibilities some pelvic valve leak in this kind of situation. Yeah. That's my comments. And another thing is, I agree, is 29 maybe a little bit too big on this situation because she's laterally small and there's a loop that doesn't look like that big.
Yeah.
It's based on the pigtail, the size. Sometimes I look at the pigtail and then see what's the annual size. And in this view, the pigtail doesn't look like it's a really big annulus.
Mm-hmm.
Yeah, so
that's
we'll see.
Feeling.
I think the 20 balloon with an injection sounds like a nice.
Yeah,
a nice way to try to help.
It's a good discussion point, actually.
Okay.
And I can see your point. It is a bicuspid valve, by the way, and it's a very interesting. It's really, for me anyway, fairly atypical because the raphe is not calcified. It's fused. Definitely, you can see that it's moving. It's moving into that area. So I'm not so much concerned about the oval shape. For me, it's a very interesting case because the bicuspids that I do see in China or even here or in Japan, they're a lot different. Huge calcifications. And I agree with you, that big chunk, I'm not never worried about a lot of calcium if it's distributed, but these big chunks, there you can see it. There's always, a little bit of a point here because the valve doesn't adapt, and there might be a little bit of a leak there.
Yeah.
Anyway, thanks for your comments, and I think we might proceed and let the guys.
See how it goes.
Let the guys work. And we said, since it's 9:15 and we have a little bit, that we do the sizing together and go through the case together.
Okay.
Hopefully that's okay with you.
Yeah, that's good. Wonderful.
Okay.
Okay, we already insert the wire and the pigtails, and we measure the LV pressure and outer pressure. Yes, this is truly stenotic aortic valve. Peak pressure gradient is more than at least 60. So true stenotic aortic stenosis. So.
Yep. LV diastolic pressure is very low.
Yeah.
Yeah. And then I like to insert a safari wire.
Yeah, we're using the Safari, the Safari or Confida, as you mentioned before, David. I think, you know, the
Do you have a
time
preference,
of
Eberhard?
the time of pre-shaping wires, I think, is basically for at least for the most part, it's over, and consequently, the complications that we initially had with perforations, I think it's past its history. Even though, believe it or not, it happened even in the United States. When you push
you
the
can't
wire,
shape the wires. That's usually where we always make fun of our surgeons because they weren't very good at shaping the wires.
right,
So that was,
right. So this is a Safari.
Yes, this is Safari wire.
Safari small, medium, large?
Medium. No,
Medium.
I think it's large, right?
I don't know.
Oh, okay, he doesn't know, but I think it's large. Anyway.
It's one of those wires, okay.
Yeah, one of them.
Can't be very large. I mean, she doesn't
Well,
have a very
to be
large
very
ventricle.
honest, and you can see the aorta is a little bit different from the previous case. It has the tendency to be, okay, this is LAO now, to be a little bit more horizontal than the one that you saw before, which came pretty straight. So the horizontal parts are not so ideal for the core valves, as you know, because the coaxiality is always a little bit.
That's one of the things if we have a very horizontal root, we try hard not to.
Rightfully
use a core
so.
valve.
I agree with
it's
that.
It's just harder.
Yeah.
This is the GMED balloon, 20 millimeters.
So he put the 20 millimeter ZMED in.
Yeah.
Pulls the pigtail back, which, I mean, this is, honestly, you think this is routine, but I can tell you many people don't know how to balloon size, actually.
Okay.
We don't do very much.
Yeah.
Ready? Are you ready?
Yeah.
Yes. Pacing on. Inflation. Contrast. Deflation.
How about that? 20 millimeter.
Yeah, you can. Wow. That's
Pacing off.
And, I think it is helpful, actually.
Can we, after you pull that back,
Could
let's
you
take
show
a look
us
at that
again?
again?
Absolutely, yes. Very well done.
와이어 조심하고.
Yep.
Okay.
Well, definitely.
Could
So
you
that's,
show us
uh,
again?
Yeah, let's look at the balloon.
Yeah.
Could you
Very
show us
well
again?
done. Thank you.
다시 한번 보여줄래요?
I think.
Let's.
Okay.
Here we go. So there's the balloon, pacing. Nice inflation, really held very steady. So who wants to put a 29 core valve in? There's no hands up here. Who wants a 26? 26? Anybody? Who wants smaller than that? Do we have 26 down here?
Yeah, we have a 23.
And we have a lot of nodding for a 26, I think. John, what do you think?
The bicuspid valve, the balloon, sometimes I do a balloon sizing for the bicuspid valve, but the interesting for the bicuspid valve, even use a very small balloon, they don't intend to leak. So sometimes it can be a little bit for misleading because bicuspid a little bit different from tricuspid valve. You put a small balloon, you don't leak.
Yeah,
you don't see the leak. So,
but look at how, I mean, like the STJ is so tight on this.
Right.
Yeah.
But for this patient, you can see the pulley fall. Like when you put a balloon in, the calcium move to the sinus valsalva, there's not much room really left in the sinus valsalva. So I really choose a small one rather than bigger one. The 26. If for the sapien valve, I have a little concern for the 26 valve actually in this situation. But for the core valve, I think you need to oversize a little more. So I think 26 maybe I think a reasonable.
What do you think, Eberhard?
Yeah,
what
I
is
think
your
for the points that you mentioned before, David, the sinus is small. It is actually not a big anatomy overall, what you saw. So I think you're totally right. The 26 given the sinuses and the leak with the 20, I would feel much better with the 26 than a 29.
I think so. Now in Germany, do you have the Evolut Pro in Germany?
Oh yeah.
Yeah. You do not have it though in Korea yet, right?
No.
Jung? No. So would you? I mean, are there any cases nowadays if you have the right size, that you don't use an Evolute Pro, Eberhard? Is there any
Well,
reason
basically,
you choose
David, there are two things that are different from the United States. We have to pay a premium for the Evolute Pro.
Oh, okay.
So, and the price is not low. So you carefully think to use a Pro versus the Evolute R. For example, in a valve-in-valve situation, I wouldn't use Evolute Pro because you know that's good enough with the Pro with the R. Here, I usually probably would use a Pro, but I hope that we're going to be doing okay with the R. And the disadvantage or the downside is that the French size is a little larger. So we're paying a little price for the Pro part. But here in the bicuspids, I would probably use Pros overall, I would say.
Yeah, I mean, as you said, we don't pay it. I don't know if you could say it's an advantage in the U.S. that we don't pay a premium. I think we pay a premium for both. So we don't pay any less for the R. That's true. So we pay more than you do for both of those valves. But I think this is a case where certainly in the States we would use an Evolute Pro.
Yeah.
These days.
I agree.
And in Canada, John, Evolute Pro also. Yeah. But I think an R will do very nicely also.
So they're loading. The ladies are busy getting it done.
Okay.
So another thing I want to point out is the balloon size. So usually we use the very small balloon. So just open the stenotic valve, 18 or up to 20. So in this case, to select the 26 or 29, some operator can select the 23 balloon or 22 balloon. So look at but regarding the safety of procedure, we prefer the smaller balloon, less than 20 or sometimes 18. What do you think of it?
I mean, especially if your valve isn't ready, so it would, if you got torrential AI, it would be, a difficult situation.
Yeah,
so it's
exactly, David. I wanted to point that out when they were ready to doing it. Now we are doing the testing, the loading. Usually, the best of care is that you pre-dilate or balloon size, whatever. The valve should really be ready in case you have a lot of AI. You really have to move quickly. So that's a little bit off. But here, honestly, I didn't feel so bad about it because there was not a lot of calcium. So I wasn't too much concerned about it. But that's not good practice. But I think that the balloon sizing, in this situation, I think it helps. We'll see what the results are, obviously. And
so Eberhard, in Germany now, when you do a typical commercial case, no special anything, how many people are in the lab with you?
Oh, less.
How many few?
Well, it's basically the first operator, second operator, and then we have the loading person, and we have one of our fellows doing conscious sedation.
So not an anesthesiologist,
No.
just the cardiologist like we do for PCI?
No. Okay, so
very,
he's
very,
getting
very
into the... Yeah, so we are maybe 4 or 5 people. So
close to a PCI size.
Yeah, and now we can see he entered the valve, and he gets into the position. Maybe we can come back to the coplanar view and bicuspids a little bit later. So what he does now is he takes the parallax out, so the ring is in one plane, which I think...
So do that coming caudal? We've started now doing that going LAO.
LAO caudal.
You go LAO caudal now.
Yeah. I think that looks very nice. You want to deploy? Are you team or should I do it?
Sure.
No.
You should do it. I just hold the
Well, I can
device.
do it. I mean, so I don't want to talk too much now.
No, you pay attention. We'll talk.
No, that's okay. I have to say, without putting him under pressure, but Dr. Ahn is very, very cool. Yeah, hold the wire. That's good. Very cool, and he...
Test it, please. Test it.
Do you intend to implant high?
Yes. Without. I mean, he should answer the question, not me.
Yeah.
I'm just a
goal
peon
would be
here.
Maybe a 2 depth if you can.
Yeah.
Yeah.
Always makes you a little nervous to implant very high.
Yes. I do this part slowly.
Yeah. Good.
I think
You
That's the
direct
nice
me,
thing about
boss.
core valve is
Yeah.
he's so patient.
Slowly.
Will you start
open.
to pace or will you not pace?
No.
No pace.
No pacing.
Okay, good. I think it's good. Good. Test, please. Okay.
It's pretty good.
Yeah.
Pressure is down.
Yes. Up, please.
Pressure's back.
So first of all, I could prove that I can deploy, right? I mean, turn the wheel.
Good job.
조정해주세요.
Thanks.
After thousands and thousands, you've been able very professional.
Beautiful. I think, anyway, was a nice deployment, very, very quiet. As you can see, Dr. Ahn does it the way I like, I have to admit. No pacing, generally no pre-dilatation, and I keep also the pigtail there. Because I feel so much safer as far as depth is concerned, as far as movement of the valve is concerned, if the pigtail is there. If you pull the pigtail at the very last minute, you're lost. And you really don't know what the valve is doing. So
Yeah, we always leave the pigtail.
Yeah, so we do the same thing.
Okay.
And this is the time, pressure is good.
Yeah.
This is the time where you judge
Yeah.
depth.
So do you want to do a full aortogram now?
Wait, just one sec, David, I'm
Oh,
sorry.
right
The depth.
I'm impatient, sorry.
No, so am
Go
I. But, you know, because now everything is stable. What you could do now is, if the depth is not good, resheath and do it again. Here, I don't think we don't need to do it.
Depth looks perfect.
Yeah, that looks good. The other thing is, if you inject now, I mean, we do it because you said it, and he wants probably to do it too.
Yeah.
Usually I don't, because what you do is the PVL you cannot judge from here, because you're injecting outside
No, yeah, no.
the valve. The best
Just to
thing.
see the size.
Yeah,
I think.
exactly.
Size and it really confirm the position. I think we have that big calcium nodule, so it's not very hard to tell where you are. But it's always a little hard to tell on the left corner side how deep that is.
Yeah.
So we would at this
Shall we
point
deploy?
do an aortogram.
So
Aortogram. Test it.
Okay.
One more test.
Oh, wonderful.
yeah, I think that's
a perfect,
really
that's
nice.
a perfect depth. Yeah.
Just a moment.
See, he's the boss. He's great.
Leave. Okay.
No, it's beautiful.
Release the tension.
Yeah,
before
release the
deployment.
tension.
Yeah, and then more and more and more. Okay.
So you give it a little push.
Yeah.
Yeah.
Give a little push on it to.
Yes,
Keep the tension
actually,
off.
this is an important part there, David. And here you can see whether you have an experienced or not experienced. Because if the valve is like this, when you release, the valve always comes up if you don't take the push out. If you are deep, like on a 6, then you can actually don't have to do it, because then the valve slips up 2 millimeters. So I go step by step.
Yeah,
I mean,
okay.
slowly now.
Very slow, yeah.
Okay. I push it a little.
Yeah, he pushes
Okay.
it. Very nice.
Good.
Okay, released,
We're all off. Good.
all off. And now you do your job here. Pay attention that the
됐죠?
So here we always pull the wire back a little to make
Yep.
sure we are in the center as we come back.
and you can see the sinuses are filled. See, there's still contrast there.
Wow.
Beautiful.
That's a beautiful deployment. Let's hope the result looks as good as the deployment does.
Well, let's see.
Keep the wire inside.
Yes.
Okay.
So
Stay
question for
here.
you, Eberhard. So do you use a wire to take out the pigtail, or do you just gently pull it?
Using the
Life case always.
Always with a wire?
So now it's time.
If I'm doing a live case, I'm doing it with a wire. If I'm with fellows, I'm doing it with. If I have a lawyer appointment at noon, I pull it.
Okay, it's time to evaluate the echo.
에코.
Yeah.
Yeah.
튜브 좀 돌려주세요. 튜브 좀.
Can we
Tube.
pick the pigtail up?
Okay, I know. Yeah.
Eberhard, is there any situation where you would pace while deploying
Yes.
this valve?
Yes. I would do it if the valve really. Dr. Park, he wants to confirm that we're doing well. So, yes,
doing
there
fine.
is. If the valve is really bouncing
Yeah.
for PVCs or anything, then I think it would make sense to get a little bit more of a stable.
And And then you pace at a rate of about 120 maybe?
Yeah, exactly. That's central. Oops, I'm sorry, I don't want to.
Yeah.
No, I don't want to. Let the echocardiographer talk.
Do we have a microphone on the echocardiographer?
I don't know.
Yeah, sure. I have. Yeah, but I'm looking at the echo, but I need time to evaluate the parabolic leakage.
The hardest part about being the echocardiographer for TAVR is because we're always in a rush.
Yes.
You're always fighting with the come on, faster, faster.
But at least the diastolic pressure is pretty good.
Yeah.
No,
So
I think
at least
That's central there.
Yes.
yeah, central area mainly.
And you still have the stiff wire there.
Yes.
I moved to apical view.
And you did this with the inline sheath, right? The 14 inline?
No.
You
He did
this with an
18.
French
yes,
sheath?
18 French sheaths we used.
Is that your standard?
No. Not mine.
What about
But
Dr. Ahn?
this sheath is more convenient to us,
Yeah.
so we preferred the
So
18
you
French
usually will use the
sheath.
sheath unless
Yeah.
unless the arteries are very borderline?
If artery is borderline, we use the inline sheath, but artery is too big, enough big, so we prefer the conventional 18 French sheath.
We always use the inline, I guess.
Yeah, we do too.
I have to remove the pigtail.
But it is nice if you, I mean, if you have the room for the 18 French sheath, it's not bad.
I think the parabolic leakage trace, just trace, mainly central area.
Trace
from-
paravalvular, good.
Yeah.
So given bicuspid, that's pretty good. So now we are wiring out the pigtail.
Yep.
Please give me the wire, another wire.
It's tight in there, huh?
Yeah.
Yeah, that's why you have this little contrasting. I think once the pigtail is out, the contrasting. He's really doing it nicely. I'm not that patient.
Do you hear resistance?
They must. I
Yes,
think
some
that's
resistance,
kinda
so I have
tugging
to
at it a
use
little
a more stiffer wire to remove it.
Which wire is that?
This is a stiff wire. Push the wire and pull back the pigtail.
Maybe captured by the calcification.
Yeah. So I think the depth is okay. I think, if not mistaken, it's like 2.
I think about it too. Yeah.
Yeah, it's nice. He was very cool, very stable.
So don't force the pull out the pigtail. Sometimes it made some pop up the implanted valve.
Shall we do the hemodynamics? Or you want
Do
to?
you want to take the stiff wire
Sure,
out
we
before
have
you do your
so
aortogram?
we have enough time, so we can measure.
We have
Yeah.
13 minutes,
Yeah.
I think. We can watch you do your closure. if you want to,
Yeah. Actually, let's see. We take the device out.
You want to put the pigtail in?
I would,
Yes.
but
Let's see how that. And her QRS is the same?
Yes.
yep.
Yes, QRS is not wide. Yep.
Production, wonderful. I want to keep that record of 4% pacemakers intact for you guys. We're still so amazed.
Yeah.
마이크가 안 들어졌어요.
Unbelievable.
네. 네.
It's lower than surgery, I think.
Yeah.
So I think this
True.
is
Yeah,
due.
true.
I
You
think
haven't
this
seen
is
my
due to
surgeries.
the different practice. In our centers, pacemaker rate after AVR is just 1 point something.
Oh, okay, it's still higher than the surgery. Okay. Everybody's careful. Partner, they were both 8% in partner 2. Yeah. Surgery and TAVR. 30 days at least.
See, now the diastolic pressure is like 68 or something.
Yeah, it looks good.
Yeah, it looks. I
how
think it
the,
looks good.
How the LVDP is. And we said just trace on the echo, right? Trace
That's
on
what the. Yeah, it's TTE, right?
TTE.
Yeah.
TTE, yeah.
That looks nice.
Ah.
Wouldn't you agree?
Yes, that's fantastic hemodynamic.
Even James has to admit that.
He's smiling.
I know he is.
He is
This is a perfect.
No, you don't have to overdo it. Good is okay.
Your EKG's a problem. Though. Look at that. Yeah, very fuzzy.
Yes.
Yeah, it's
some noisy.
they said
The
that
leads
this
fell
is
off.
this room. It's not.
It's beautiful.
It's not
that
us.
you can't beat that. That's
Yeah, that's very nice.
So will you take the? Do you want to take the pigtail out of the ventricle for your final aortogram?
Okay.
Make it as good as possible.
Well, you know, when I do these cases here, David, just I can't say between you and I because the audience is there and we're full. It's always the competitive situation here because he likes the Sapien and you know, and he does the core valve. He always looks, what is the result? And I'm always relieved if the result's good.
If your aortogram looks good, we'll call it a tie.
Ready?
Yep. Yeah, that's a little less.
It's a little AI. Yeah, that's maybe a little more than trace. I don't know, mild.
Yeah, I would call it mild.
Yeah.
Less than mild.
Okay,
I don't know if you need to chase that.
Yes,
No,
this
I
is a
don't think
routine
so.
view. This is a routine view of it to evaluate the PVL.
Yeah, definitely. You know, a little bit there.
Yeah.
I think, but does anybody feel strongly that we should post-dilate this?
I think it seems to be mild, and anyway, the core valve will get bigger later.
A little bit of growth over time.
Yeah.
Anybody, DW, any interest in post-dilating? Or are you happy?
I think the result is excellent, and looking at the flow, the status of AR, I think that the mild AR and hemodynamics also showed AR index graphically more than 3.0. I think this is the result is excellent.
So I think it's good.
Good.
I think it's a very good result.
Yeah, with a 1 minus, we accept that.
I think if you had an Evolute Pro, it would be even a little.
Yeah,
even a little,
that would be a
cleaner.
little bit different.
But this is a very nice result, and I think the valve size was absolutely correct.
Yeah.
Right? I don't think maybe go back to the other aortogram just to look at the sizing one more time. The previous aortogram. So I mean,
So
if you put a 29 in this, I mean, it would be the SDKs
well, it would have been really bad. I agree.
Yeah, it would have been huge.
Actually, you could even argue about a 23 here.
But I think this is a very good choice.
No, I
very
mean,
good
I know,
choice.
but 29 would not have been a good thing. Yeah. See, the sinuses are really filled, you know.
Yeah.
It looks great.
Yeah.
So we have 8 minutes. So anybody want to do a song or a dance or a?
No, I just wanted to thank you all for this. Thank you very much. Great having you. Thank you very much for your guidance, and we'll see you in a bit.